Today's episode of the StallSide podcast was brought to you by Root and Riddle Veterinary Pharmacy.
Bud, how are you doing today?
Nice day. Foals are coming, hitting the ground, and we're going to talk about a little bit about that today.
Yeah, absolutely. We're going to talk about a really important syndrome, focal mucoid placentitis, which is colloquially known as Nocardioform.
Yep, and there's some talk about it. There's a little bit of an uptick this year. So what is it? How do we treat it? What's the outcome? So we have a couple of our experts from the hospital to talk to us about this.
Yeah, we're very lucky today to have both Doctors Schnobrich and Dollen from the Theriogenologists service talking about this. And it's a very complicated syndrome. It's like very insidious onset, can be difficult to diagnose. There's really no systemic way that we can diagnose this condition in mares. We have to actually ultrasound the mare to have a look at it. And it's a condition that nobody really knows what makes it occur in some mares. Can be sporadic, can occur in outbreaks. And so it's very complicated, but potentially economically devastating.
Yeah, it has some devastating effects. So let's get these two in here and talk to them about it.
Yeah, okay. So on StallSide this week, we have Doctors Mirage Schnobrich and Karen von Dollen from the Root and Riddle Theriogenology service talking about focal mucoid placentitis. You may know it as Nocardioform. Dr. Schnobrich and von Dollen, welcome back to StallSide.
Hi, guys.
It's a party today. Thank you for coming.
Thanks for having us.
Yeah, that's great. So pretty interesting topic we're going to talk about today, and it's very timely, Nocardioform placentitis. So would between the two of you like to describe what this syndrome is and how it's actually important reproductively to the mare?
I would first like to, point of order, just move away from Nocardioform placentitis and more broadly describe as focal mucoid placentitis.
Oh, that's right.
Well,
yes.
Yes. So do you want to explain why?
Well, as recently shown by our colleague Pugliadini, it is not just Nocardioform organisms that are present or can cause this classic presentation of this mucus present at the interface of the uterus and placenta. And so, by limiting ourselves to Nocardioform, we're pinning it into a narrow box that it doesn't deserve.
And I think that's a really good point because for a long time, people have thought about this as a very narrow syndrome. Mm-hmm. And actually by expanding that out, maybe it's going to help us think about it a little bit differently because the problem with this syndrome is we can't reproduce it experimentally. We really are a little bit lost when it comes to the pathogenesis of it, but we're all pretty sure about what the effects are. So would you like to describe what you will see in the pregnant mare when they're affected by this mucoid placentitis?
Sure. Yeah, I can describe basically what we do know, and then we can kind of yo-yo. She's here to keep me on task. Keep me in.
I have a long memory.
Yeah, that's good. She's tough. I love it. But so basically what we do understand is that something is happening not at the cervical star, which is where we see ascending placentitis. Usually your vets are doing transrectal ultrasounds and they'll see thickening of the placenta and bacteria coming from the vagina cranially and causing a very severe inflammatory process that can end in abortion. This is really different, and we do think there's we have a higher incidence here in Kentucky, but it's been found all over at this point. It's been reported in California, Pennsylvania, Maryland. So it's not just a Kentucky problem. We've had two kind of outbreak series around 2011 and 2020. And what it is when the mare delivers the foal and the fetal membranes, you'll see these brown peanut butter lesions at the base of the horns. And when they try to isolate the bacteria from those, they've traditionally been in this group that we call Nocardioform. And what it is a slow, we don't know why or how it happens, but basically there's a loss of the connection between the fetal side and the maternal side, and then this purulent material kind of mucoid stuff develops there. It's really tricky because with our traditional scanning and looking for it, a lot of times we don't find it until we have a mare either abort or she's has premature udder development or bags up early, and then we know there's a problem. But because it's sort of an insidious disease, it doesn't always cause changes on ultrasound that we recognize, and it can go and progress to very large lesions before you actually have a problem. So it's a tricky disease for us to deal with, and as practitioners with working in repro and trying to identify this, it is definitely challenging. It is thought to have less inflammation than the ascending placentitis, which results in kind of a tricky outcome when we talk about, if you identify it, is the foal definitely going to be small and dismature? Because we get such variability in the outcome. They can abort, they can have big lesions and abort a normal or deliver a normal foal. There's so much variation depending. And why would you say that is, if you're talking about like the uterus and growth restriction or...
Well, I couldn't say for sure, but I think part of it is just the need for the growing fetus to have all of that placental surface area exchanging nutrients. And when you deprive them of a small area or a large area, then you're limiting the amount of groceries they can get from the dam. And so that's likely contributing to what we see clinically when they then are delivered.
Yeah, yep, I would agree, yeah.
And I think that's a good point to make too, because they really do need all of that real estate. Because essentially the uterus is maxed out, supplying everything
and
that
especially
fetus needs.
Late in gestation.
Yeah.
That's why we start to see the problems
Yes.
those last month or two.
Yep.
Yeah. So any sort of situations weather-wise, any situations farm-wise, anything that tends to be a pattern with the occurrence of this condition?
You want to take that one?
Sure, yeah. Well, it's been shown that there typically is an increase in cases after these long, dry summer drought conditions. Is the most consistent feature of these years where we have these big spikes in cases. But aside from that, we don't know a whole lot about how it happens, why it happens, and until we know that, preventing it and diagnosing it early are both going to be really challenging.
And I was impressed with how much that they've done to try and figure out where this comes from, introducing it at breeding in the middle of their pregnancies, and just can't reproduce it.
Yeah, they've given it intravenously, orally. Like when we had MRLS, they found that by basically intubating with the setae from the caterpillars, it reproduced those signs. Well, they tried this with the bacteria that they were isolating from the placentas that displayed the signs. They just couldn't get it. And Dr. Caniso did a lot of work on that with Dr. Ball, and that's been continued by some great researchers who are working on it now and really trying to make some advances. And Dr. Fedorka did a great study here in Kentucky looking at all these cases and trying to get information. And from the farms were great. They contributed blood samples. And of course, that was a year that we didn't have a ton of it. So, but it is challenging. And hopefully, as we get some more assays to identify it, potentially in blood markers or things like that, we may learn more about the disease process.
The organisms themselves, right, there tends to be a bit of a range. What is unique about these organisms, or what about their growth characteristics lend themselves to turn up in this location, causing this problem?
They live in the soil, and they go to this ventral part of the uterus, and they grow very, very slowly. They're branching actinomycetes.
Yep. Just kind of, they're, as a group, they're gram-positive, usually found in the soil. And in terms of saying why they grow in that area, I think Pugliadini did some good work looking at the DNA that was present in these placentas and what organisms were there, and actually found a couple different things that sort of suggested we have a lot of bacteria and things that are present in the uterus, even in normal pregnancies. So what causes them to then proliferate, we're trying to figure out. And there is some new work suggesting that certain strains of the Nocardioform associated organisms might produce certain antimicrobial effects or things that inhibit the immune system. So it may be something like that's that. But honestly, I have no idea. I think we're still trying to figure that out. But it is different. A lot of times with our ascending placentitis, you have a beta strep infection, and that is a very inflammatory process. This really isn't. I mean, Dr. Von Dollen's got some beautiful images that show if you went quickly over this lesion, you wouldn't even notice it. There's not a lot of edema. It doesn't change the fetal fluids that much. And we'll show you guys some of those images.
Let's look at them.
Yeah. Whereas in ascending placentitis, the fluids change, they get brighter, which might suggest, more protein, and and we don't see that as much with this. All right, go ahead, Dr. Vondel. You got it.
Oh, sure. Well,
Yeah.
so here's an ultrasound image transabdominally, and you can see here that there is diffuse thickening of this CTUP region. The fetus is deep to the screen, and then the mare's body wall is close to the screen. So this is almost 20 millimeters of depth of that abnormal CTUP. And then here again, a little bit more narrow, just 13. But again, if you were going quickly, it doesn't really jump out at you until when you're scanning, you can just see the CTUP coming together here, how it comes together, and that exudate's not separating, and then here it balloons out, and then coming together again. And so that it can be easy to miss on transabdominal ultrasound. And then the other really challenging thing about diagnosing these is just if you think about how large the uterus is, and how limited we are in what we're able to actually visualize when we compare our little ultrasound probe and the mare's enormous abdomen. Mm-hmm. And so it can be really hard to identify these lesions. Here's a bit more of a dramatic bulge of the mucoid lesion, where it really bulges here and is quite a larger abnormal region. And this is all the same mare that I followed along during her disease progress. And again, this is all fetus here. So here's some umbilical cord, a little more umbilical cord, fetal body here, and this is our abnormal region, and that's over 4 centimeters of separation of this thick, tenacious exudate. Again, just illustrating that. And here's another video of that, how it comes together, and then kind of.
And then it's really exciting because if you hold it, you can see it swirl, which is pretty gross. Mm-hmm. It makes,
which is amazing, because when you get it out physically, there's no swirling there.
Right. It's just this thick.
So thick.
Mm-hmm. And then the other thing that's interesting, if you have a vet like Dr. Von Dollen who's going to catch these early, if you start treatment, what's fascinating is a lot of times the fetal membranes that come out are just bald. There's no slime. So people say, oh, she didn't have Nocardioform, but it may be that you treated it effectively, but you've lost some of those microvilli. So anyway, that's another great picture. If you're wondering what it looks like, she's got some great pictures.
Well, this was the same case that actually ended up falling out at the clinic, and so this is that really just a lot of this classic thick pus that we're dealing with that's very classic for the disease process. This foal was living, but did not have adequate ossification of her carpal bones, and so was humanely euthanized. But illustrating the extent of this disease process.
Yeah, it's pretty impressive.
And I was sort of picking up on what you said before. I mean, like a strep ascending placentitis is a strep ascending placentitis, but this group of organisms, like being in the soil, sort of going to favour those things that grow in regions that maybe don't have so much oxygen, right? And so this is quite a unique location. And another point, people think the uterus is sterile, but it's not. And so they're sitting there, and the way it sort of separates the membranes is sort of unique.
It is, yeah. And without, as shown in her images, it just sort of slowly separates them, but you don't see thickening over, which is, we think of thickening of the chorioallantois or the fetal portion as edema and inflammation, and sometimes you don't see any of it. So
and you mentioned some of the recent work by the group out of California and Belgium, with Dr. Dini there, is that when they're looking at some of the transcripts there, the inflammatory response is not that high, but there's actually also a downregulation of the compounds that are involved in creating new blood vessels.
Yes.
So you start to think it's creating this environment which is not very oxygen rich, but is pretty well nutrient supplied, and so they are pretty sneaky bacteria to do this.
Yeah, there's some, and there is. I think you had mentioned, Bart, we see it in that last month, and there was a farm that I had followed every 30 days that had quite a bit of it, and what I noticed is they really didn't develop lesions until 270 or later. I mean, sometimes the really bad cases from around 250 days you might see something, but they would be fine, boom, 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 and then all of a sudden you would see a lesion. So it's interesting, it's almost like the conditions are optimal. And that's just us hypothesizing. I mean, it's...
Yeah, we're not. So it's not like we're seeing abortions at 180 days.
Right,
That are,
that's
that are
right.
caused by this. It's all very, very late, last month type things.
Yeah.
So abortion's just one potential outcome, but you can have a foal that goes to term, and then those foals are not born weak. So Peter, why don't you take us through that just a little bit?
Yeah, 'cause some of these, when you find them, they actually have a placental lesion. They have this mucoid material, but the foal is perfectly fine, because I think it comes down to how much of the real estate of the uterus has actually been involved, and also whenabouts in that foal's development this came about. So they can actually get through that, and sometimes it's an incidental finding, because we'll talk a little bit more about detecting this, but sometimes it's exceptionally difficult to detect it.
Yep.
Because of its location and the fact that you may not necessarily be looking for it because the mare's not giving you the cues that she has a problem. But some of the foals, if this happens early enough in that period of late fetal development, like the last 6 to 8 weeks or so, they're doubling in size in there.
Yeah.
And so their nutrient requirement and metabolically things are actually very, very active. So that fetus is grabbing every nutrient it can from the placental unit. And so it's very unfortunate, but some of these are very compromised late in the piece. And if they are delivered early, they seem to have had the stress response where they actually get pulmonary development. So they are actually viable, but from an athlete, they're not viable because the ossification of the cuboidal bones especially is not accelerated by that stress response. So you'll have foals that actually are perfectly viable from a life standpoint, but they're actually not viable from an athletic standpoint. And those are really the unfortunate ones. And they can get to like early 320, sometimes mid 320 days of gestation. And we have that scenario, and then you suddenly start to realize how important it is that they get all the nutrition that they need, that the uterine environment is perfect, and they get as long as they need in there, and that their residence in utero is not shortened by this condition. So it's difficult from that standpoint, in that sometimes you don't know this is going on. But backing up a little bit, how do we detect this in the mare? What is available, what's coming? But in a field situation you guys are faced with, where you see maybe a little bit of precocious mammary development, what's your thought process going through for how you're actually going to detect this condition?
Yeah, and I'll maybe you can go through the screening that we do. One thing that I would like to answer, because we see such variability in the foals, a lot of times you'll hear the argument, if the mare is precocious udder development, there's no point in treating her. You're already too far. You're not going to get a good foal. And I think with this disease, it's really important to understand that you still can get a viable foal with treatment and resolution. You're not going to get the placenta or the fetal membranes to reattach to the dam's uterus, but there are mares that we've looked at that you look at lesions and say, we're in big trouble, and they get a healthy foal.
Yeah,
so don't give up.
And it's important to understand that the foals are born, they're not septic, they're not affected by the bacteria. It's stuck in between that layer between the placenta and the uterus, and it's not getting to the foals. They just weren't getting enough to eat.
And if you can keep them in there, I've been pleasantly surprised how well some of these will come out. And you're right. And you look at the placenta, you're talking about the villous nature of the placenta, and you look at this and it says, wow, this was a significant lesion, or we've seen the pictures like have been shown previously of all this detachment. And they actually manage to get through that if you treat them. So let's talk a little bit about detection, and then let's move to treatment.
I thought each of you just raised really good points, and yours with the rapid increase in the metabolic requirement that I hadn't previously thought of it. But that's such a good point. And then to highlight the lack of sepsis in the foal, that's also critical to remember, because it's very different from our ascending placentitis cases where those foals can be so sick. But in terms of screening, keeping regular serial monitoring transrectally, and then as you get into later gestation, transabdominally, is going to allow you to catch these before they become externally apparent, where you are playing a little bit of catch up. So if you can catch it beforehand, get that mare on appropriate treatment based on seeing something on ultrasound, then we can do a lot of good with these cases. And it is an investment to do this, and from both time and finances, but can be really well worth it if it means saving the foal.
Yeah, absolutely. And I think some people, we know what the treatment is for placentitis, so the temptation is just to maybe treat everything, and that may hold, it probably does do positive things in some cases. But if you don't know how big the lesion is initially, it's hard to gauge because sometimes the antibiotics you're using may not be appropriate. So the screening is really helpful because we can initially see how big is the lesion. Is it getting better or worse with our treatment? Because we may need to modify treatment. So there really is, I know a lot of farms that have pretty good success with kind of the blanket treatment 1 week a month. We're really trying to get away from that and for a couple of reasons. But it's a decision that the farm manager has to make based on finances and things like that. And there are also, another thing that's frustrating about this disease is a lot of the blood tests that you might think would help, such as serum amyloid A or some of the inflammatory markers, are really not helpful in these chronic, slow-growing disease processes. And even the total estrogens and progestogens, and there was a recent study that said the progestogen ratios, and albumin is very sensitive for ascending placentitis. We don't have something like that. A blood test at the moment. There are some in the works, but at the moment we don't have something that's a slam dunk.
Well, that gets back to the way this disease occurs and its location. It's sort of actually quite local, right? And so for that mare to systemically notice that something's going on between all of those layers, between where the mucoid material is and the bloodstream, I mean, it's very difficult to actually detect that. And if you were looking for inflammatory markers, like you mentioned SAA, well, that was going to be the great savior for everything, and especially in this situation. But you're right. It's been and gone by the time that this condition becomes a problem. And how do we have anything that's going on in there that's actually going to be systemically recognized by the mare, number one? Number two, there's so many other processes going on in the mare where all of these markers may be involved. How do you actually get the signal from the noise?
Yeah.
So it's really going to come down to you guys with the ultrasound. And it's not easy always to find with the ultrasound to just serially monitor them. I think that's something to hammer home is you must look and you must serially monitor these mares. Because sometimes we have dystocia come into the hospital and it's an incidental finding. She's term, the foal is normal, the placenta comes out, and all of a sudden we've got this plaque, this mucoid plaque.
Yeah.
And all routine foal watchers come in for another reason. Say she has an orthopedic issue, and we're scanning them. It sort of says, "Hey, why have one problem when you can have two?" Right.
But even the problem with serial scans is it doesn't do you any good to start looking at 8-9 months.
No,
you're not going to find it. You're not going to see it until so much later. It has an advantage on us because we can't find it until it's fairly well advanced.
Yeah.
I agree. And I do think screening's important, but I think it's in this later stage, and hopefully there's some very smart people working on blood tests that are going to be useful for us to limit the screening that we do. So ideally you could do a blood test, identify animals that have markers for this, and then use the ultrasound so that you're not having to screen the whole group. But I truly believe now the best way to find it is doing the transabdominal, not the transrectal, because the transrectal, a lot of times you won't find it unless it's very advanced.
Yeah. Price of freedom is eternal vigilance.
Anxiety.
That's one of your American favorite things, isn't it? Yeah. So now we've actually found this lesion, no matter what size it is. How are you guys going to have the conversation with your client? This is how we need to treat, and this is the duration, and how do we move stepwise through the drugs that we have, depending on the severity that you find.
You want to field that, whatever you tell.
I'll start and then you fill.
Okay,
you fill
sounds great.
Okay.
There'll be a lot, nothing to fill in. Go for it.
Well, so if we see a definitive lesion, then antibiotics are obviously going to have to be part of our treatment protocol. Another challenge of these is that we can't go in and just get a sample of that for culture and cytology that would tell us, here's what drug we use for this. And so we're treating empirically based on what we know about the behavior of the majority of these bugs in lab conditions. And so we have some broad spectrum antibiotics that we can reach for. Sulfas and gentamicin or doxycycline have been typically the ones that we'll start with. If I start a mare on one of those and I'm monitoring her and I'm not pleased with the progression of the visible lesion, then I'll typically have a brief washout period, make sure she's on a probiotic, and then flip-flop antibiotics to see if the other one is going to have a greater effect. And then as a mainstay of all these placentitis cases, also having these on anti-inflammatories, progestin support to promote myometrial quiescence, and anti-inflammatories, and then anything we can do to improve blood flow through these compromised regions of the placenta.
Do you have a preference for anti-inflammatories?
Yeah, so actually, thanks to Mariah's input, I have started using Flunix and Meglumine at the start of when I diagnose a case of these, and then switching around to Firocoxib, and have been really impressed with how quickly the Banamine really can take down the inflammation, and especially if they have premature mammary development, it can have some pretty rapid resolution there, and then keeping her on Firocoxib with less side effects for more long-term maintenance. And then keeping your point about how you're never going to get that placenta to refuse where that abnormal region is, and so keeping her on some supportive meds out of consideration for that.
Okay. You mentioned blood flow to the uterus, so the classic one's aspirin, pentoxifylline?
Yep, absolutely.
Okay,
Yep.
both.
And it goes without saying, if you start some of these, for example, if you have them on aspirin, Banamine, pentoxifylline, genomycin, it's good to also screen the effects, because some of these can be very hard on the gut and the kidney. So you can do certain things like Gastrogard to try to prevent ulcers, just thinking about the whole horse. And I think you asked the question, how long are you on? It really depends on how big the lesion is and how it responds. So there is a possibility of taking them off quite a bit of the medication if you see enough improvement. And I've seen mares go from 4-centimeter pockets 1 week to gone. You can't see it, but you can tell there's something different in that interface. So it's pretty impressive. And also it's interesting, we can monitor, we've used this, you've used this too, Peter, is the total estrogens, which is a marker of fetal viability and also placental function. And a lot of times when we take this, if they're before 300 days, we see it can be very low, which would suggest it's very compromised. And with treatment, that will actually rise up, which would suggest you're having some positive effect. A lot of it's, you're hypothesizing it, but we do see improvement of clinical signs, improvement of outcome. You can't save them all, but if you want to try, I think it's worth trying. Mm-hmm. And to talk to the client, if it's a big lesion, they're going to probably be on these medications, because you're just trying to stop its progression. Hopefully you can get the bacteria to regress, but the biggest thing is making sure that separation and loss of interface doesn't continue to expand, so that you really don't get enough nutrients.
Well, that's the thing. You can't restore that placental function, but
Right.
at least you can stop the deterioration. Now, you mentioned a couple of antibacterials, potentiated sulfurs, doxycycline. Is there anything that is really not effective in this situation? Because we are limited in choices we have in equine medicine.
Yeah.
But is there anything out there that's sort of been tried and really hasn't done in your hands, your experience?
Ceftiofur.
Yeah, ceftiofur. I mean, I think when we think about treating placentitis, one of the things that we look for are medications that can travel
Yep.
from the maternal blood into the fetal fluids. And so really there are antibiotics that have been tested and do reach reasonable concentrations that they should kill the bacteria that we see. Again, this is debatable, but that would be penicillin, genomycin, doxycycline, enrofloxacin, and the sulfas. And then ceftiofur exceed is unfortunately not one that we see that gets across the fetal membrane. So in this disease, it would be questionable, because you could be treating the endometrium, which it reaches good, but I would probably be wanting to go with something that crosses the membranes, just so you get the best.
Well, the other thing is a compliance issue as well, because
Yeah.
if you're in a situation where you're repeatedly injecting this mare, if you're
Absolutely.
using like a depot ceftiofur preparation, she ain't going to want to be injected every 3 to 5 days.
That's right. And it's not great if you get a colitis and
Yeah.
you still have them on a long-acting antibiotic. So in any placentitis, it is really tricky, because you have them on so many medications that if the foal dies, there's a high likelihood that she will just retain the dead conceptus in the membrane. So making sure that fetus is still viable is really important. You can't just put them on the meds and say, I'll see you in 2 months. You need to keep checking, because she could develop, the fetus could die and just sit in there, and then she could get very sick, just like a retained membrane.
Yep.
So that's another kind of consideration.
Yeah, so the question is going to be, my mare has mucoid placentitis this year. Is she going to do it again?
Oh, good question. Karen knows the answer to this, so I'll let her know. Go for it. You wanna do it?
Fortunately, no evidence that it is more likely to recur in mares. We know that it's overrepresented in older mares, but that's the one like mare factor that has been shown, but doesn't affect her future fertility even in that same season. Very few mares will even culture these Nocardioform type organisms on if you were to lavage them after delivery of a Nocardioform type fetus. So that's wonderful. That's good news for us that it doesn't persist and linger.
Yeah, that's a really good point. They're not, the next breeding season, if the mare had a Nocardioform abortion or you saw it in the placenta, you're not concerned, I'm not concerned with that mare going into the next breeding season. It doesn't mean that, whereas if she had high drops or something like that, there can be some really negative.
Or a cervical defect and you got to send
Right,
a placentitis,
exactly.
right? Yeah.
Yep.
But at the same time, they're not developing immunity, right? So
Right.
they're not, doesn't mean that they're not immune from it the next year.
That's
Correct.
exactly
Yeah.
right.
Yeah. So
Which is too bad.
Which
which
definitely-
really makes you sort of think it's like a set of conditions in that uterus
yeah.
and maybe some environmental impact that actually creates an environment. And it's so remote from the mare's immune system anyway, really, when you think about it,
Yeah.
because it's... So you mentioned it occurs in other places. This is taking things back a little bit. Are there any areas which it occurs more often than others?
Oh, Nocardioform specifically?
Yeah.
Yeah,
As
In
far
the
as
United
regionally.
States?
Yeah, in the United States.
Okay. Yeah, I would say Kentucky
Yeah.
is a hot spot. I know that it's reported. I know around this region is a big issue.
Yeah.
And there are also horses that have shipped from New York or wherever, and they will develop it later. So we see all sorts of variations of it. Horses that have been in Kentucky and get shipped north in areas that it's not endemic or not an issue. And that year they'll have mares that were on the farm and shipped in that have the lesions. So it is very confusing in terms of where it is. But I would say we get it the most
Absolutely.
here.
By
Yeah.
far the most. And
Yep.
there's sporadic case reports of other ones that
Yeah.
pop up, a Nocardioform reported
Yeah.
in this state or whatever.
Yeah, so that really does get back to your environmental thing when you mentioned about the season leading into this, and maybe there's management things, maybe there is unique environmental things, pasture things to this
Yes.
area that we just haven't worked out yet, because this is an extremely frustrating condition because people live in fear of this condition. They'll start to talk. Have you heard about this? And then all of a sudden it bubbles up and then these cases start to appear. And so it is something that really causes a lot of fear amongst the industry.
Yeah. Yep.
Rightfully
And
so. Yeah.
Yeah. Well, this has been a fascinating tour through mucoid placentitis. We all know.
we were going to bring live samples, but these guys said no.
Yeah, no, fair enough. But if you want to go to your peanut butter jar, you'll
There
probably
you go.
see exactly what it is because everything has a food analogy, right?
Yeah, unfortunately.
And of course, everything has a food analogy. So, any questions for our guest?
No, I think you guys
artist
did a great
here?
job. Appreciate you running us through that. And it's like you said, it's a concern for people, and it does have a devastating economic impact on our industry, and so it's a concern. But like you said, there's some really smart people working on it. I have no doubts they'll work it out. Hopefully sooner than later, and we'll have an answer for it.
Yeah, and it's heartening to see that with so much pressure being put on this condition, that there is actually some really good information coming about what is actually going on at the site of the lesion. My concern is it's so remote from the rest of the mare. Developing some sort of screen other than what you guys are doing every day by ultrasounding the target region.
Yep.
It's going to be really hard to see how we can easily find a systemic marker, because that would be the key. And as I say, SAA was the great hope, but it just didn't work out. So that was StallSide for this week. We've been talking to Dr. Schnobrich and Dollen from the Rood and Riddle Theriogenology Service on mucoid placentitis. See you next time.